Medurstand Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and today we are going to talk about another arrhythmia, the most serious and the most dreaded, ventricular tachycardia or ventricular fibrillation. We have covered all these topics. Last time we had discussion on atrial flutter and fibrillation, but ventricular tachycardia and ventricular fibrillation is the most serious one and can occur anytime and can be fatal. Those deaths you must have heard people, they just develop some chest pain and they die, and sometimes somebody dies during sleep, and it is generally believed that it is because of ventricular tachycardias and ventricular fibrillation or cardiac standstill. So it is extremely important to understand this ventricular tachycardia. It usually occurs in the setting of ischemic heart disease, but ischemic heart disease could present with ventricular tachycardia as a first manifestation. And time is extremely crucial. I think ventricular tachycardia is one of those conditions where you cannot afford to waste even a minute, because one minute can make the difference between life and death. So please watch this video carefully so that you can understand this disease better. We will cover ventricular tachycardia and very briefly ventricular fibrillation also. Most of the discussion will be on ventricular tachycardia and how to differentiate ventricular tachycardia from supraventricular tachycardia with broad complexes. I will show you how to do that. Now let's see the example. And I think in my discussion on VPCs, I mentioned about R on T phenomenon, and I find it so interesting and so relevant and so important that I would like to discuss it again. Now, this is a patient. This is the rhythm. These are the sinus beat. This is a ventricular ectopic beat, this one. It fell on the downslope of the T wave, but nothing happened. But see here, on the downslope of the T wave here, and ventricular ectopic came, and that triggered ventricular tachycardia. And this is a run of ventricular tachycardia, this one. How do we know? We know it from the looks of this ECG, and we also know from the clinical condition of the patient. Okay. So if a VPC, sometimes this VPC may be documented, sometimes it may not be documented, but it is generally believed that some VPC, some premature beat, falls on the downslope of the T wave, and that triggers ventricular tachycardia. Now, why the downslope of the T wave? Because during ventricular depolarization, ventricles are refractory. Even during most of the repolarization, ventricles are refractory, so no VPC can occur. Only in that part, and the downslope of the T wave, which corresponds to differential depolarization, some fibers are still depolarized and refractory. Other fibers have recovered and are now in a position to respond. And by the time they will respond, some more fiber will recover from the refractoriness. So this will trigger the ventricular tachycardia. And that is why ventricular tachycardia is commoner in those patients who have long QT syndrome, because having long QT syndrome means that the vulnerable period on which a VPC can trigger ventricular tachycardia, that is longer. Okay, so this is VT triggered by this R on Q. Now let me please explain R on T again so that you understand the concept well. So these bars, they indicate the period of initial depolarization followed by repolarization. Collectively, these are actually periods of refractoriness. So when ventricles are completely depolarized, all fibers are refractory. When ventricles are in repolarization, initial part, again all fibers are refractory. But in this part, this fiber, for example, has recovered from the refractoriness. This one has not. This one has again recovered and on this point. So different areas of recovery, and this is because different muscle fibers, they have different electrical characteristics, their position, location, their size. So just imagine that on the downslope of the T wave, different muscle fibers are in the different states of refractoriness. This is what is required. And once the last fiber is also recovered, then there will be no problem again, because all muscle fiber are in the state of responsiveness and you will just have normal VPC. So if a VPC falls here, that triggers ventricular tachycardia. This is the complete refractoriness, and this is the vulnerable period, and then again there is no problem. Okay, so this is the part. Those who have long QT syndrome, they have longer vulnerable phase, and that is why they are more likely to develop VT. Now, when you examine somebody and somebody has VPCs, now somebody has VPCs which come late, they are less likely to be serious much after the T wave. Okay, if you examine an ECG and you see the VPCs, there are VPCs, but they occur significantly after T wave, you can feel assured that this is not going to be serious. But those VPC which come early in this part, they are likely to go into the VT. These are couplets, two VPCs occurring together. This is a VPC before recovery occurred, before there was a compensatory pause, before there was another sinus beat, there was another similar VPC. Two VPCs, they came from the same focus. We can tell from their morphology. So there is some ectopic rhythm in the ventricles which discharged twice, but then sinus node took over. Similarly, you could have three beats in rapid succession. This is the triplet, or you could have quadruplet, the four. Technically speaking, if you have four beats in sequence, this is called a short run of VT. Short because it is not sustained. If it continues for a significant period, then it will be called sustained VT or simply VT. So you can see these VPCs, four total. Now this is the true, I think, today's lesson. This I'm going to spend some time here. You can see that this patient ECG, you can see 1, 2, 3 AVR, AVL, AVF, V1, V2, V3, V5, V6, V5, V6. One thing which is very obvious, and if you see the rhythm step, one thing, I think two things are very obvious. To me, actually, three, four things are obvious, but two things which should be obvious to you also. One is there is very, very fast rate, right? Maybe 250 plus, very fast and very regular. See, there is very, very regular. Now, you may be surprised that ventricular tachycardia is more likely to be regular than sinus rhythm, because this is not under the influence of our normal sympathetic nervous system. This could degenerate into fibrillation. Once it becomes fibrillation, then it becomes irregular, and sometimes we have a polymorphic ventricular tachycardia. That might also be irregular, but the classical VT is very regular. So very fast, very regular, and broad complex. And you can hardly tell which side is the upper side. If I just turn this ECG like this, and you would not be able to tell, you can only tell from these labels that this is the upper side, this is the downside. Now let me now pinpoint some of the important things which will lead you to understand and diagnose that this is actually a case of VT. Complexes are broad and rate is 214 beats per minute. I calculated. You can check it by magnifying this image on your screen, but this is 214. Most VTs have heart rate of 200 plus, but this is electrical rate. You might not be able to feel the pulse. This patient may be completely collapsed. Then there is, I think you have already noticed that the complexes are broad. Then there is something called AV dissociation. Now, what on earth is AV dissociation? Very important concept. You must understand it. Please bear with me for a few minutes. I'm going to explain to you what is AV dissociation. The word AV dissociation is actually self-explanatory. That means atria and ventricles, they are electrically dissociated. That means both have their own independent rhythms. There are two conditions where you see AV dissociation. One was AV nodal block, complete AV nodal block. I'm not sure if I mentioned this word there, but AV dissociation occurs in complete heart block also. But it also occurs in ventricular tachycardia like here. So you can identify, if you can identify that there are two rhythms in this ECG, that would mean that there is AV dissociation. In AV nodal block, the ventricular rhythm is escape rhythm. Ventricles started beating because the current was not coming from the SA node. That was a lifesaver. But in this situation, SA node was working and is perhaps still working. But because of some autonomous focus in the ventricles, because of probably some ischemia, some focus in the ventricle became autonomous and started discharging more than sinus rate. You know the law of physics applicable to heart, whichever pacemaker has the maximum rate, that governs that takes over the heart. Okay, so in this case, since ventricle rate is 214, it has taken over the control, and this is what you see. But occasionally you might see an SA nodal activity penetrating into the ventricles, causing a small depolarization. Sorry, I take it back. The atrial depolarization will never enter the ventricles, so you will not have any ventricular depolarization of sinus origin. Okay, but atrial activity is going on in the atria. Sinus nodal activity is going on in the atria. So that you can see, you know, these ventricular depolarization, they cannot go back into the atria because AV node wouldn't allow that. So for SA node, there is nothing happening. Ventricles are beating at a very, very fast rate. Atrial depolarizations are not entering ventricles, but they are depolarizing atria. So occasionally you may see atrial depolarization. Now this is one example. You see this T wave and this T wave are different. This is different because there is perhaps a P wave superimposed on this QRS complex. So if you scan these QRS complexes and you see some deformity somewhere, you see some here, some here, some here. So these are actually indicative of superimposed atrial depolarization. Okay. So these atrial depolarization, they do not enter ventricle, but they are recorded in ECG. This is called AV dissociation. Then this is precordial concordance. Now what is that? In ventricular tachycardia, we have seen that all precordial leads, they have their deflections. All precordial complexes have their predominant deflection in one direction. And normally, you know, V1 R wave evolves, it grows in size, and then ultimately it becomes very tall. S wave initially big, it gets smaller and smaller, and ultimately in V6 very small. But in Vt, all the complexes may be directed in one direction. Minus V1, you just ignore V1, V2 predominantly downward, V3 predominantly downward, V4, V5, V6 all are downward. That means the ectopic focus is perhaps in the anterior wall, going all the depolarization are going backward. So all the anterior leads are recording them as downward deflection. This is called precordial concordance. This usually indicates that the focus, the origin, the pacemaker is in the ventricles. That is another important observation. So all these things, I think, collectively tell us that this is a case of ventricular tachycardia. I'll go through some other differences also, but in this case, we have seen broad, fast, regular heart rate, no P waves identifiable as such, but P waves superimposed on QRS complexes indicating AV dissociation and precordial concordance. All these indicate that this is a case of ventricular tachycardia. What are the criteria? First of all, there is no sinus rhythm. This is the ventricle is governed by the ventricular rhythm. There is sinus rhythm perhaps identifiable in the form of this AV dissociation. QRSs are usually broader than 0.12, 0.12. That means 3 small squares. Rate is 200 or more. There are ventricular tachycardia where the rate may be less. Idioventricular tachycardia. There may be AV dissociation, and then occasionally there may be capture beat. Now let me explain what are the capture beat. Capture beat means that ventricles, they are getting their current from a focus from the ventricles, but occasionally this atrial depolarization might find ventricles in a responsive state. Because of these, ventricles are in almost constant state of refractiness. It would not allow any electrical activation from another focus, but occasionally, especially if the ventricular rate is not that fast, and occasionally a P wave or sinus beat might enter the ventricles. Now, how would you know? If you have a narrow QRS complex somewhere in the middle of these broad complexes, that would be recognized as capture beat. Then we may have fusion beats. Fusion beat is nothing more than a capture beat superimposed on a ventricular depolarization, giving you a morphology which is sum of sinus depolarization and ventricular, this ectopic depolarization. Then precordial concordance. So we don't have capture beat and fusion beat in this, but if you can see them in some rhythm, that will be very diagnosed. I hope I have clarified the concept of ventricular tachycardia, but I'm going to discuss in some more detail because this is extremely important condition. What do you see here? Complexes are broad, are irregular, heart rate is very fast, but rate is 160 beats per minute. There is no AV dissociation. All these complexes are of the same morphology. Of course, ventricular tachycardia should be considered in this case. Maybe in fact the diagnosis by default, but if you know the history, if you know the ECG, if you have seen the ECG before or after this, I think that might help you to differentiate. So there is right bundle branch block pattern, no concordance. This is actually a broad complex, but paroxysmal supraventricular tachycardia. This patient had pre-existing right bundle branch block. Because in this patient sinus beats were also broad, so the supraventricular tachycardia will also present as broad complex. This you would know once patient is out of the tachycardia, and if you see this basic ECG showing right bundle branch block, especially the circumstances also. If patient is stable, then it is unlikely to be VT. But the rule is if you're unsure, treat it as VT. So previous or ECG following cardioversion is very helpful because you might discover a pre-excitation syndrome or pre-existing bundle branch block. Now in this table, I'm going to sum up some of the features. Some I would explain in detail, others I would just leave for you to pursue and dig in the literature, and I'm not going to spend time there because I think they are not common and important. So first thing is how to tell if it is ventricular tachycardia or paroxysmal supraventricular tachycardia with aberration. And you know, by that I mean existing right or left bundle branch block, or pre-excitation, or rate limited block. Okay, so these three conditions. Of course, if it is narrow, then there would be no differential. Narrow complexes are SVTs. So in this situation, you have to differentiate. One basic difference is the setting in which that condition develops. Ischemic heart disease, this ventricular tachycardia is usually a manifestation of ischemic heart disease. Patient may or may not be a known case. It may be the first manifestation, but it usually happens in the setting of ischemic heart disease. Age is usually more than 35 and patient is unlikely to be hemodynamically stable. Blood pressure is likely to be low. Patient may be having shock. Patient may be having pulseless status. So that is the condition. But of course, that does not mean that every patient with ventricular tachycardia would have all these. Some patient may be stable. Paroxysmal supraventricular tachycardia with aberration, patient is likely to be younger, less than 35, and there may be previous history of SVTs because I told you these are paroxysmal VTs, paroxysmal supraventricular tachycardias, and usually at the time of presentation they are stable. Their sensorium may be intact, they might not have any chest pain, they may not, their blood pressure, pulse may all be okay. Now I'm going to expose some of these points and explain to you. QRS duration is if it is more than 0.16, that is surely VT. Not to say that all VTs would be 0.16 or broader. Some would be just 0.12, but if it is broader than 0.16, it is surely VT because this much broad QRS complex you cannot have in any of these conditions. Okay. Then AV dissociation, if present, you are sure that this is ventricular tachycardia, and I've already explained what is AV dissociation. Capture beats, again, if present, ventricular tachycardia. It will not be present in all, but if present, indicate ventricular tachycardia. Fusion beats, if present, they indicate ventricular tachycardia. And precordial concordance, if present, indicates ventricular tachycardia. And Brugada sign, positive, negative. I'm not going to go into detail. Jobson's sign, again positive, negative. You can read the literature. Northwest axis, self-explanatory. Cardiac axis, I think again I will not go into the, it is actually what is called no man's land. You know, you could have left axis deviation, you could have right axis deviation, and there is an area which does not belong to right or left. It is no man's land or northwest axis. If axes are in that range, it is likely to be ventricular tachycardia. Then typical bundle branch block pattern may be seen in these conditions. In this it is not the case, and if there is no clue, VT is likely. If there is no clue, you just receive a patient with this type of tachycardia, I think VT is likely. Paroxysmal supraventricular tachycardia with aberration is less likely, or at least you are going to treat it as VT. Treatment, I discussed this in detail in my earlier videos, so today I'm going to just focus on this. At the time you receive the patient, you very quickly examine the patient, see especially if the patient is hemodynamically stable, if patient is conscious, blood pressure is measurable, pulse is okay, then you could use medication in the form of intravenous lignocaine or amiodarone. And of course the treatment is not our domain, but just one of the two things can be tried. Or if patient is hemodynamically unstable, the blood pressure is dropping, or patient the sensorium is less, or patient is in a state of shock, then you would go for some treatment which is immediately and very predictably effective, that is direct electrical cardioversion. Of course, details I cannot discuss here because we are only discussing ECG. Treat as VT if in doubt. Even paroxysmal supraventricular tachycardia can be treated with DC shock. So if you treat this patient with DC shock, probably you have not done something wrong. You have saved a life, because if he had VT and if you misdiagnose it as SVT with aberration, this patient might end up in complication or may just collapse, and then you might not be able to do anything. So this is another VT, and like I told you, this is upward, downward, upward, downward. I'm sure you know this word, torse-headed D pointers. It's a dancing type of rhythm, up and down, up and down, up and down, and this is a feature of ventricular tachycardia. Then this is monomorphic and this is polymorphic. Monomorphic and polymorphic ventricular tachycardia. So, right, these are both are ventricular tachycardias. If patient with ventricular tachycardia collapses and you don't see any pulse and you record an ECG and you see this kind of rhythm, this is usually taken as ventricular fibrillation. Usually complication of VT or sometime complication of sudden ischemia, and this would mostly lead to sudden death because there is no effective ventricular contraction at all. Thank you very much. I hope this module was useful, because ventricular fibrillation, ventricular tachycardia are truly lethal diseases, and if you can save one life, it is as if you have saved total humanity. You know, in the world, defibrillators are available in many public places, the airports, in the shopping malls, and people are trained to deliver DC shocks. So if you find somebody collapsing instantaneously, that may also be ventricular tachycardia, and it is a standard practice to deliver DC shock if available. Of course, you need to know the technique, but if you know, after doing resuscitation, maybe you can save one life by delivering DC shock. To my knowledge, this facility of cardioversion is not available anywhere except the intensive care setting, the CCUs in the hospital, but I hope in future we will also have this facility available in marketplaces. This has been Professor Aziz-ur-Rehman from Medurstand, and I really look forward to see you in my next video also. And I think we have covered almost all arrhythmias, and we have covered most of the ECGs, but just a couple of more modules to cover some less common conditions, and then we will be done with ECG module. And if you are interested, we can start some other topic. Thank you very much, Professor Aziz-ur-Rehman from Medurstand.